Today we're speaking with Dr. Devin Effinger, who's a postdoctoral researcher at the University of Colorado Anschutz campus. And he's a friend and colleague I got to spend some time with at the recent Neurobiology on Psychedelics Gordon Research Conference, which was a pretty exciting event. And he was able to present some of his work on the potential real-world risks of microdosing using some preclinical models. So thanks so much for jumping on a call today.
Yeah, absolutely. Quite glad to be here.
I'm guessing many people who'll be listening will be familiar with the sort of general concept of microdosing. But for those who don't know, are you able to sort of describe what microdosing is?
Absolutely. Yeah. So microdosing really refers to like the consumption of what we would call like a sub-hallucinogenic dose of a psychedelic. I think what's implied with microdosing is that this is done in like a chronic fashion. So it's taken anywhere from like 2 to 5 or even 7 days a week. And so, yeah, the idea being that taking a sub-hallucinogenic dose across time at least anecdotally, seems to produce some sort of elevations in mood, improvements in cognition and creativity. And so that's where the scientific interest stemmed from, really these anecdotal reports of improvements.
Right. And this is quite different from the current trials, typically sort of phase 2 and phase 3 trials with things like psilocybin that are looking at one or several very high doses of a psychedelic with much larger gaps in between. This microdosing is that sort of chronic dosing at various intervals at sub-hallucinogenic doses.
Yeah, I think a rule of thumb is like a tenth of a dose or so, right? So if you're talking about 25 milligrams of psilocybin, which would equate potentially to around 2.5, 3 grams of psilocybin containing mushrooms, we're talking about like zero point 0.1 to zero point 0.3 grams of mushrooms, a typical dose.
Right. And this, presumably has a lot of the same challenges that psychedelics clinical trials have, in that people might have material of sort of unknown purity or provenance. They typically are aware that they've taken a dose of something, so that you'd expect there to be sort of expectancy and placebo type effects going on there potentially. So what is the level of clinical data currently that supports microdosing for any application, whether a therapeutic indication or for creativity or anything else?
Yeah, so the data's been pretty mixed, but largely unimpressive. So it seems to be, in a lot of these trials, it's similar to a placebo effect. The studies sort of suggest that this is largely driven by placebo. I
Right.
will say, though, an exception to that. So, first of all, there have been studies with low dose or what we'd call microdose, ranging from anywhere from like 10 to 26 micrograms of LSD, where there are neurobiological effects through EEG,
Right.
increased neural complexity, changes in alpha theta, even fMRI. There's been a study showing some changes with a microdose of LSD. So that's, in my opinion, suggests there's obviously something happening. But in terms of clinical outcomes or therapeutic outcomes, really the only study that kind of sheds some light on this came out of Harriet DeWitt's lab. I think it's
Mhm.
Mola et al. 24. And essentially, they did a study comparing people with high and low Beck depression inventory rating. So
Right.
not fully depressed, but just somebody with high depressive traits versus low. And what they found was that the people with high depressive traits were more sensitive to the subjective effects.
Mm.
And 48 hours after, there was significant reductions in their BDI score, with
Right.
no changes really seen in those with the low BDI score, the low BDI score
Mm.
group. So that kind of suggests that potentially the neurobiology underlying depressive versus non-depressive states may also play into the sensitivity or effectiveness of a low dose application of a
Mm.
psychedelic. So I wouldn't say that there's nothing going on for those that with depressive symptoms. It might be efficacious, but essentially, long story short, the effects are mixed and largely unimpressive.
Right. It's super interesting that there are some signals there, but teasing out potential placebo level effects are quite challenging. I guess we could say in that sort of classic scientific article sign off, further studies are warranted. And I know some others around the world. Another colleague, Vince Polito in Sydney, is looking at very low doses of psilocybin several times a week for sort of moderate depression in young males. I think people are starting to get more focused in terms of what they're looking at with some of these studies. These are drugs that typically hit many of the 5-HT receptors. And of particular note here, I guess, given the frequency of dosing for microdosing regimens, is this finding a number of decades ago that fenfluramine and potentially other serotonergic drugs can lead to valvular heart disease and pulmonary arterial hypertension following sort of chronic activation of 2B. And to the extent that fenfluramine was withdrawn, the FDA has issued guidance for people working in this space at the moment with psychedelic inspired compounds that this is sort of an anti-target in terms of their regulatory consideration. So what's known, because I believe this is sort of the motivation for your study, what's known about the real world risk of chronic 5-HT2B activation at the doses of psychedelics that people are using for microdosing?
Yeah, so there's basically people have written review papers acknowledging the fact that there is a potential risk given the fact that serotonergic psychedelics like psilocybin and LSD are agonists at that serotonin 2B receptor. So a large body of work with Brian Roth and other people identified following the whole fenfluramine situation that it seemed to be agonism of the serotonin 2B receptor that was the culprit. And so at this point, I think we're pretty clear on the fact that 2B is the culprit. But really, in terms of psychedelics, like nobody had really, it's a question mark. Outside of 2B agonism, we don't really even know at what point is it chronic activation in terms of kinetics? Is it into biased agonism at the 2B receptor? I mean, the actual mechanism below, or sort of building on just the fact that it's 2B agonism, is largely unknown at this point. So aside of the fact that due to their pharmacology, we knew that psychedelics posed a potential risk, in terms of dosage or frequency, that all is unknown.
Yeah, it's a really good point. So, for those who are not aware, in terms of magnitude and sort of frequency of activation of 2B, this is presumably quite important because fenfluramine was repurposed and approved for Dravet syndrome with quite a different dosing profile, I believe. This question of frequency and dose with psychedelics in microdosing is probably enormously important. What was your sort of approach here to thinking about how to get some good real-world data using available preclinical systems?
Yeah, so basically, armed with the knowledge of this pharmacology and the potential risk, and then just looking at like how basically nothing had been done, I sort of looked at what tools we had at hand, and we had, I work with mice in terms of the preclinical stuff that I do. We had LSD, and then luckily for us, we had a preclinical cardiovascular core that offered services to include echocardiograms, which basically it's a non-invasive way of imaging heart function and structure across time. And so that opened up the possibility to perform a chronic dosing experiment wherein we were giving either doses of LSD or a negative or positive control, be it vehicle versus high dose serotonin or fenfluramine over the course, so 5 days a week for 4 to 8 weeks, depending on which part of the study we're referring to. So that was
Right.
sort of the approach is, basically let's test this out. Let's give dosing. Um, we also utilize the head twitch response as a way to sort of engage or choose a dose that we felt would be what we consider
Mm.
sub-hallucinogenic. And so that was basically our approach. Pretty
Awesome.
simple and basic experiment.
Right. Yeah. It's super cool. And as far as I'm aware, this is probably the first study where someone's attempted to mechanistically, explore this relationship between a dose of any psychedelic and various heart defects following chronic dosing. So what's the high level summary of the findings?
Yeah, so basically we followed that protocol. We did a baseline echocardiogram. We began dosing 5 days a week, did a 4 week and then an 8 week scan to initially look using high dose serotonin, which in the literature had shown the ability to promote hypertrophy or a thickening of the left ventricle. And so we did that for 8 weeks. And basically, for that part of the study, we found that with our positive control serotonin, we saw evidence of valvular hypertrophy. So we saw
Right.
a reduction in the inner diameter, a thickening of the posterior wall diameter, and a decrease in the volume or the amount of blood that could be held within the left ventricle chamber. In our positive control serotonin group, which was obviously an important group when we went into this, in that we needed to be sure that we could
Mm.
see pathological effects in our hands using two different doses of LSD. So we did zero point zero 0.01 or zero point zero 0.03 milligrams per kilogram LSD. And in neither of those groups did we see any sort of evidence of valvular hypertrophy. We went on to do a study incorporating fenfluramine, a known valvulopathic drug, and we did that for 4 weeks. So basically, in that first round of experiments, we saw that the most robust effects were at 4 weeks.
Right.
So when we did the valve study, we just went out to 4 weeks, did chronic dosing of 10 mg per kg fenfluramine versus our high low dose LSD, the zero point zero 0.03, and saw evidence of valvular regurgitation in our fenfluramine group with no difference between vehicle and the higher dose of LSD.
Right.
And building on that, we partnered with John McCorvey to look at some of the pharmacodynamics, comparing mouse and human serotonin 2B receptor. Saw no differences in binding activity for serotonin as well as LSD, psilocybin, and norfenfluramine, which is the metabolite of fenfluramine,
Mhm.
psilocin, excuse me, not psilocybin. And then building on that, the sort of ending to the paper is that we did some pharmacokinetic calculations, doing some modeling based on human literature of plasma levels across a 24-hour period, in with our human binding data to basically assess or predict what the kinetics would look like over time. And it became very clear that fenfluramine at the dose that it was used produced an incredibly robust activation of the serotonin 2B receptor that is persistent through a 24-hour period.
Yeah,
This is
because of differences in DMPK, presumably, and the fact that it's taken at a much higher dose and more regularly, potentially.
correct. Yeah, and it was a
Yep,
daily drug, right? So
yep,
basically, after a week of taking this, you're getting pretty much 100% activation of your serotonin 2B receptor
right.
chronically, versus 3 milligrams psilocin and a 20 microgram LSD. I believe and basically for both the low dose psilocin and LSD, within 10 hours it was off the receptor. Again, these are calculations based on human plasma and human binding EC50 data, but
Yep.
essentially it sort of illuminated a potential mechanism to this valvulopathic effect, where it seems to be that it's the chronic activation, the sustained
Mm,
activation across time that would be necessary, which
right.
kind of makes sense when you think about biologically the process of cell proliferation, right? The activation of these 2B receptors is mitotic on cardiovascular tissue, is a pretty expensive process. It would just kissing the receptor probably isn't enough to really engage that to any degree of severity versus chronic activation,
Yeah.
obviously.
You can sort of speculate from that scaling that, even with a hypothetical sort of daily, very low dose of the two psychedelics you've modeled, you're never reaching that point where you have chronic, highly efficacious activation over an extended period. Because I believe with fenfluramine, it was daily at a high dose, and people typically would see effects within several weeks of dosing, right? I think Brian Roth and others showed that yeah, that was probably sufficient, given that you had kind of saturated exposure of the receptor to start getting some of these really serious valvulopathic effects. But that's awesome. So I guess sort of a limited data set, but probably the first of its kind and a good indication for the many people that probably microdosing. What's sort of the future direction for the studies? I can see an obvious number of interesting sort of questions that could be answered with this approach for other drugs or in terms of dosing. Do you have any sort of immediate plans to do additional studies there?
Yeah, so I think, a caveat here is that I'm a neuroscientist. Everything that we do in the lab is neuroscience. So this was a total like side quest based on necessity. Like I was just sort
Right,
of at a place where it's like, well, why has nobody done anything to actually test this? And luckily we had the resources to be able to do so. But that being
right,
said, the first step would be to get some kind of funding to do more research in this realm, but certainly MDMA is a known cardiotoxic drug. Again, having a similar sort of kinetic profile to fenfluramine in that we see elevated levels in the blood across a 24-hour period that could then lead to activation of this 2B receptor. So there's we know that MDMA at some level is cardiotoxic, but lingering questions would be the frequency, dosing, as MDMA is hopefully getting back to a place where it reaches a level that would be more accessible. Gaining insight into questions in that regard is going to be important. Like how often can you do MDMA therapy before it begins to pose a potential cardiovascular risk? Ibogaine
right,
is another interesting compound that we know has cardiotoxic risks,
mm,
but are not quite sure exactly why or how. The
right,
mechanism as to why ibogaine poses cardiovascular risk is relatively unknown.
mm,
Beyond that would be to build off of this LSD using osmotic pump across time to really get at the mechanism, right? It's presumably if we can have sustained release and sustained activation of 2B across time, we would see some sort of cardiotoxic effects. That would
yeah.
be my guess.
Yeah, well, it's super excellent work. I think it lays a really nice sort of groundwork for others, yourself or others who want to start filling in some of the data gaps in this kind of emerging and increasingly important area. And I believe it's just been accepted for publication, right? I was lucky enough to see it at the GRC, but it's now been accepted and peer reviewed and will be online shortly.
That's right. Yep. We published ACS Pharmacology and Translational Science. They got a special issue coming out. So it was
Awesome.
just accepted a couple days ago.
Oh, congrats. Yeah, we'll be sure to highlight that in the newsletter for sure. Awesome. Cool. Yeah, thanks so much for your time today, Devin. It's great speaking with you.
Absolutely. You too.
Alrighty. Bye.
Bye.
Yes.